was wondering if you could tell us first why you decided to enter the field of medicine.
Well, that's kind of a long story, but is it on?
Yeah.
Okay.
If it's off, I won't pick up that.
I was in another field before I got into medicine. Actually, I was studying to be a Roman Catholic priest for 5 years before I decided that that wasn't the course of life for me. So I left and the seminary, then went into the Air Force for 3 years and was a training officer in Lackland Air Force Base in San Antonio, Texas for a few years. Then I came out and decided instead of the religious life, I would take up medicine. And I didn't have enough sciences to get into medical school right away, so I went back to Boston College and took 4 years of sciences, all the science courses they had in 2 years. And because I wanted, my grandfather was a doctor, and I thought maybe that was what I should be doing instead of being a priest. And I thought of having family life was important to me as well. So when I finished the 2 years at Boston College and all the sciences, then I applied for Tufts and applied for a few other colleges, I mean for medical schools, you know, in the area. And decided that stay close to home. I was accepted at Tufts and went in 55 and graduate 59. And decided that I'd probably like to practice in pediatrics around my own native Massachusetts. So I was accepted up at St. Vincent Hospital for an internship. That was rotating in those days. And then did extra training in pediatrics for a few years. Then decided to settle in Shrewsbury because there wasn't any pediatrician between Worcester and Framingham. So when I came into Shrewsbury, I was very, very busy immediately. And as a matter of fact, I was seeing patients as a chief resident at St. Vincent's on the side because they wanted to establish themselves with me. Hearing that I was going to go out in Shrewsbury, they wanted to establish themselves with me, and it started off with a big bang. And I was busy the minute I stepped into Shrewsbury.
So was it just yourself?
Just myself, yeah.
Wow. You hear a lot of stories of people who are just hanging out waiting around for people to show up, and mostly be family and friends.
I know. This was good because the minute I opened the office, it was just an apartment, actually, that I had changed around, and I was all alone, had no secretary, and did all of the work myself in setting up the the office. Had a friend of mine who was a carpenter build a couple of cubicles so we could have a little privacy in the office, and then we went from there. Before a year was out, I had so many patients that I needed a secretary and couldn't do it all myself. So it was very busy.
Take a step back. Do you remember how much it cost for you to attend Tufts?
It was between $1,000 and $1,200 a year, I think, something like that.
Did you have to take out any loans to do that?
My father was a businessman and helped me quite a bit. I did have partially a bill of some of the veterans benefits as well. So that helped me going back to BC and taking the science courses, and then helped me the first 2 years I was in medical school. And my dad picked up my third and fourth years in medical school, along with me working in the summer. Yeah.
How do you think the cost back then compares to the cost?
Oh, of course, I have no idea what the cost is now, but it must be about 10, 15 times. What is the price of a cook?
Here isn't bad. I think Tufts is 32, 34,000.
Is it 30? Yeah, imagine that. Wow. No wonder kids come out having big loans to pay off. It's, no, thank the good Lord, my dad paid it for me and didn't really want any reimbursement. Was just happy that I decided on some, special type of work, because he was afraid. I was the last of the Donovans, and he was afraid that if I went in to become a priest, there would be no more Donovans, so that now we've got lots of them.
Sounds like a movie title.
Yeah,
Lots of the Donovans.
Donovan's right, yeah.
What led to you choosing pediatrics over all the other specialties that are?
I just always loved kids, working with them. As a high school student up here in St. John's in Worcester, I traveled from Marlborough to Worcester every day on the bus for 4 years. I just got into a lot of things with younger kids, and just loved to be with them. And they used to talk about me as being loving kids and dogs, and they loved me as well. So it just was a natural thing for me to get into pediatrics.
Yeah. So it seems like you stayed around the area.
Yes, I said I was born in Marlborough, brought up in Marlborough, but came to high school up here in St. John's when it was downtown Worcester. Actually, was over on Temple Street, and then it has changed over to Shrewsbury. There's a nice campus over there.
So you started practicing Shrewsbury.
Shrewsbury, I started right away in Shrewsbury, set up a little office, and it mushroomed to the point where at one particular time I had between 10 and 12,000 active charts.
Wow.
Yeah.
So could you describe a typical day when you first started practicing?
Well, we were always assigned, to the outpatient departments of all the hospitals, so actually I attended Hanneman, Worcester City Hospital, and St. Vincent Hospital, and later on I got on the staff at Memorial Hospital. There was some problem getting on to Memorial Hospital, and there was a little bit of, well, we might say, bigotry in those days. And there was polarization of attitudes and of physicians, and so that if you got on to Memorial Hospital, you were fortunate. But St. Vincent's was sort of against Memorial, and Memorial was allied with Hanneman, and City was by itself, more closely related to St. Vincent's. But once the weather changed politically and religiously, I might say, too, then you could get on all the hospitals. So that opened up wide. So I was a staff member at all hospitals. So what you did, you were taking clinics in all the hospitals. This was part of your duty. You're taking monthly, what do I want to say, house service, where you took care of the indigent population and with their pediatrician. And then it changed a little bit with the advent of a lot of the social things, Medicare, Medicaid, welfare, and things of that sort. So that, but my practice, since it was in Shrewsbury, was a little more upper middle class. Although I did have patients everywhere. I had patients in Paxton and Southborough and Milford and Marlborough and Grafton, this part of Worcester. So this is why my practice. People were tired of going into the city to go to a pediatrician's office, so that mine was out in little Shrewsbury, and it was very accessible. So that was one of the reasons why I think it mushroomed so quickly.
So did you admit patients to multiple hospitals?
Yeah.
Did you have to round on them?
Yes, had to round on all of them. I admitted primarily to St. Vincent's because that's where I trained. But as time went on, I also had City Hospital patients. I had patients at Hanneman, and subsequently became the chief of pediatrics at Hanneman Hospital as well. And I was a senior pediatrician at St. Vincent's, and one of the regular staff over at City and Memorial. Yeah. So I was a busy guy. Yeah.
That must have added a lot to your hours, having to go to all the...
Well, you get up at 6:30 in the morning to make rounds. And then after you made rounds at 4 hospitals, seeing sometimes at Hanneman Hospital, if you're on house service, there were times when there'd be 15 to 20 new babies that you had to see. So and then you had to make rounds on the mothers, so that I went from Hanneman, then over to City, then maybe to Memorial if I had any patients over there, then to St. Vincent's. And that's where Barry Hanshaw came in. Barry was the first full-time chief of pediatrics at St. Vincent's. And it was nice to have him over there because he established a program for the residents. And most of the time, the attendings had to do all of the rounds until Barry came along. So we were pretty busy making rounds over there as well, besides teaching rounds. And it got a little bit hectic. Then you'd go to the office, maybe by 11 o'clock, and then you'd start seeing patients from whenever you got to the office till whenever it finished. At the beginning, it was nice that you could get out of the office a little bit early and then go make some house calls. But then that stopped because you were there from the office from 11, 12 at noon to 7 or 8 at night, every night. For the first 2 years, I didn't have a day off because there was nobody to cover me. So I was on 7 days a week for 2 years. Yeah.
So your hours must have been...
They were, you know, I'd go home, go to bed, and then pray that I wouldn't get any phone calls to go out in the middle of the night. A lot of times we had to go out in the middle of the night. We attended all cesarean sections too at the hospitals. So that was a major part of our activities because they wanted a pediatrician present at cesarean sections so that you'd get called 2, 3, 4 o'clock in the morning to attend those. And so you're pretty tired out. So one of the good pediatricians, Dr. Peter Kopowich, God rest his soul, he called me up one day and he said, "John, have you had any time off?" I said, "Absolutely none." He said, "Why don't you take this weekend off and I'll cover you." And from there on in, I started to get into a coverage system with some of the older pediatricians in Worcester.
Yeah. You said you made house calls?
Oh, yeah, yeah.
Throughout your entire practice?
No, no. It got to the point where there was no time to make house calls. With committees that you were attending, you would be spending the evening hours at the hospitals on committees, so that, and then once the rounds became a little more organized, we didn't have to spend as much time at the hospitals in the morning. So you could come down and start office hours maybe at 10 and go right straight through till 7, 8, maybe sometimes 9 o'clock at night. By that time, there was no way that you could make the house calls. You were too busy, too tired.
Yeah. So you think the main reason why you stopped doing the house calls is because the days became too long?
Days became too long, and then everybody seemed to have a car, and they just tell them, "I can't do it because I've got so many people in the office. Could you come into the office?" And they all decided to come into the office. Very rarely I made a house call unless there was somebody that was really in dire straits and they didn't have any way of getting to the office. And this is what happened. Then we started to get a little bit more coverage, more pediatricians entered the area, so we had where we might only have to work 1 out of 3 nights on call, and the rest of the time a few nights a week we were off, so to speak.
Time to regroup.
Yeah, right.
You said you were also involved with teaching.
We were. I was. I used to make rounds with the interns and the residents at St. Vincent's on pediatric wards. And then I did quite a bit of teaching when the family practice residents, interns, were organized over at at Hanneman Hospital. At that particular time, I was the chief of pediatrics, so I conducted teaching rounds with them. I never did any formal teaching as far as, the medical school, but it was always teaching rounds. That's what it amounted to. And then later on, as time went on, I got involved being a consultant for a group, a federally funded group, which was called Yours for Children. They were daycare providers throughout central Massachusetts, and they had to have medical education. So once or twice a year, I used to give 2 or 3 hour Ask Dr. John lectures to them. So you'd get up in front of this large group of women who were daycare providers, and they'd hit you with questions, everything under the sun, about medicine in general, taking care of the kids that they were, watching. And that was, I enjoyed that tremendously. Yeah. I never liked to give didactic talks or lectures. It was better to, so they turned out to be, I even had a column, Ask Dr. John,
Really?
in their little magazine paper, yeah.
Huh, what magazine?
Well, it was actually, with Yours for Children was a little periodical that they put out. Yeah.
Do they still have something like that for daycare providers?
They still do, but this is the first year that I haven't done their, they started to go to different sections of Massachusetts, and it got to be too much travel time involved for the recompense that you received. And my wife and I we have 13 grandchildren, so we've been really busy with taking care of grandchildren, so I didn't have the time. I'm busier now than I was when I was in pediatrics. So I did pediatric grand rounds once here. It was about a year ago, and enjoyed that tremendously. But as you know, as you're getting older, the subject that they give you are quite different. What was it like in the good old days was the topic of conversation, topic of the talk that we gave that time. Yeah. Which was good, fun.
So you did have a family as you were?
Family, 7 kids.
7 kids.
7 kids, now 13 grandchildren. And one of my sons wanted to go into medicine, but he got married after he finished St. Anselm's, and did some work over here in the physiology department and the pharmacology department with Dr. Emil Smith. I don't know whether you bumped into him. As a matter of fact, I think he's retiring this month. But he became a EMT, and then went further on, became a paramedic, and now is working as a paramedic fireman in Bellingham. And he should have become a doctor because he loves it. Yeah, he loved it.
What do you think it was like for your family to have a busy father or husband?
Well, we always made sure that I took a little time off to spend with them. We used to go on vacations together, and if I had a weekend off, we always went on a little trip. Mother, actually, Ellie brought up the kids. I was sort of a backup as far as disciplinarian goes, and they didn't mind it, although none of them really wanted to become a doctor, knowing that when I was home, I spent most of my time on the telephone or running out here and there for house calls. And so they were busy themselves, but they had a big neighborhood group, and we had other doctors living in our neighborhood, so that they were all in the same boat. Yeah, I enjoyed it.
So you kind of found comfort in that. Your neighbors were
Yeah.
also going to the same.
Yeah, we had, as a matter of fact, we got to the point where we had a few doctors on the same street, and they started to call it Pill Hill, the neighborhood. But it was and some of them still live there.
Yeah. When did you have your first child?
I had my first child in medical school. Yeah. Me and my wife did. She was a nurse. She was a supervisor of the nursery at Marlborough Hospital. And I met her at a wedding, and we dated for 2 or 3 years, and then finally figured, hey, this is ridiculous. Let's get married. We get married, and 10 months after the marriage ceremony came our first son. So that then we had 5 kids pretty close, and then we had a hiatus for a few years, and then we had 2 daughters at the end. So we have 2 boys and 5 girls. Yeah.
Bias towards the girls, huh?
Oh yeah, they're sweethearts. The boys are good guys too. They've done well.
Yeah.
But the girls are, I think they're my special. They kind of pamper the old man, you know. They're good kids.
Yeah.
Good kids.
So practicing in the Worcester area or the Shrewsbury area, I'm sure you've seen quite a few changes over.
Oh, I
the
see a
years.
tremendous number of changes, really. We used to spend a tremendous amount of time in the hospital taking care of our own sick patients. As a matter of fact, there were times when I had to cancel the office when I had somebody with meningococcemia or meningococcal meningitis and spend the entire day in the intense care unit with that patient. It got to the point, and then this will kill you. I sent a bill to Blue Cross Blue Shield for that entire day, having canceled maybe 30 patients in the office. And I sent a bill to Blue Cross Blue Shield for payment of that 24-hour stint that I had spent with a meningococcal patient. And I got $25. So economically, it became ridiculous to spend that type of time and not get reimbursed. So that's when the advent of full-time men helped us out tremendously in the intense care units with their full-time staff. That was it was a boon to us. And so we just send patients in, and we'd come in and see them every day. Even in the intense care unit, we would get reimbursed for the care in the regular ward, but not for the care in the the intense care units.
Yeah. So you didn't have intensivists?
Not for quite a while. A long time we had no intensivists. I think the first one that I came across was Peter Viles. Peter and I became real close friends. And Paul Marshall. Well, of course, Peter's retired too. It was nice, and then you had to call in consultants because you could, spend the time. And it became too much away from your practice, and you were seeing patients. I used to start sometimes seeing patients at 9 o'clock in the morning and go right through to late at 9 o'clock at night. In the wintertime, when you had flu epidemics, you were there you'd cancel patient visits so you could take care of all the sick ones. So it became a very, very busy, busy time. And you didn't have much time during the winter to enjoy yourself. You didn't go away in the winter because that's the time that the people needed you most.
Yeah, no ski trips.
No ski trips, no.
What did you enjoy most about practicing in this area?
I think it is the small city and rural atmosphere of course, in Shrewsbury. And you became more closely involved with the families. And you knew them all, you knew their background, you knew the history of the families, and it's still a professional relationship between you, but more a family relationship. The people used to say they loved to come to our office because it was more like going to the good old family doctor who knew everybody. And as a matter of fact, my wife, after the kids grew up, became my pediatric nurse. And my girls all became secretaries and helpers so that they knew what the old man was doing all the time and appreciated what he had to do to send them through 7 of them through college. So I just like the small city atmosphere. Yeah.
So you had your family working there too?
Yes, I had my whole family. Wife was working for a while. Well, she worked for me for 15 or 16 years. And then the girls each did 2 or 3 years secretarial work in the office. And they did a lot of work. A lot helped me quite a bit. And they enjoyed it. As a matter of fact, one of them, when she finished college, went off to New Hampshire, where she was married, and lived up there, and ran an ophthalmologist's office for him. And she knew, and then a couple of other offices as well, and she had done a lot of testing, different things in the office. We have the routine testing, that she knew all those things, so she was very handy at running a place like that.
What sort of changes did you see with what your patients would present with over the years?
Well, years ago, we had a lot more cases of meningitis, for one thing. Haemophilus influenza meningitis, since the advent of the Hib vaccine, has sort of petered out. And we had pneumococcal meningitis and staphylococcal meningitis. As a matter of fact, I was the first one to do administer intrathecal medication to a staphylococcal meningitis patient as a resident. And we had a lot of gastroenteritis, Salmonella, Shigella. We had all various types of respiratory infections. Bronchiolitis at that time was a very, very serious illness, and we lost a few patients, kids with bronchiolitis. We didn't have, and then we had all sorts of problems with, dehydrational problems. We had one particular instance I can remember that there was a new material called Litrin powder. You probably heard of Litrin. It's a powdered electrolyte preparation that you added to water to give your patients who were on restricted diet for gastroenteritis. And it wasn't told by the, I don't want to say, by the salesman to different people how to use it properly. So some of the docs were taking boiled skim milk, adding this powder to the boiled skim milk instead of, and so you had a hypertonic solution, which kids ended up having all sorts of problems: dehydration, subdural effusions because of the electrolyte imbalance, serum sodiums in the range of 190, BUNs in the range you wouldn't believe, and all because of an improper use of a material that was supposed to help kids. So we had some wild things to develop. So we learned a lot about electrolyte problems in those days. We had to do it on our own. We had some of the cases, I don't want to go into that, that's probably a little too much. But I used to do all my own taps, subdural taps for subdural hematomas post H flu meningitis. I did all my own spinal taps and cut downs, particularly at Hahnemann Hospital before we had house staff, house officers. And I used to do pleural taps as well. And we used to do bladder taps. We did them all. We had to do them. We were taught how to do them. We had to do them because we always couldn't get a consultant to do them for us, so we did it. But we were a jack of all trades in those days. When I talk to some of the young pediatricians now, they used to call the surgical resident in, or they do now, to do a cut down when they need somebody to have continuous intravenous therapy. But I probably still could do a cut down, I think. I don't know whether the hands might shake a little bit.
Upstairs and see.
No, what we used to do, as I mentioned, we did all our taps, both subdural and spinal and everything. We had.
What do you think were some of the larger technological or pharmaceutical innovations over your years of practicing?
Well, as far as the pharmaceutical things, the advent of the newer antibiotics. We had penicillin, streptomycin, chloramphenicol, and the sulfadiazine. Those were the 3 or 4 that we had at that particular time. And then with the development of resistant strains of Staphylococcus, then came methicillin and prostaphyl and some of the anti-staphylococcal drugs. Those were I think the important ones. And then we had to put chloramphenicol aside because of the developing aplastic anemias with that particular medication. But it was a great drug. When we had a case of meningitis for which we had no diagnosis until we got the cultures back, it was pen, chloro, and sulfadiazine. Sulfadiazine was given by Clysis. You know what Clysis is? No. You couldn't give sulfa medications intravenously because you'd get a hemorrhagic kidney problem. And so we used to give it by Clysis. This was subcutaneous. You mix up a solution of was saline and the sulfadiazine, and you'd instill it with a large bored needle under the skin and let it diffuse into the tissues, and it was absorbed that way. And so we used penchloro and sulfur. That was the triple therapy for meningitis until you got the specific organism. And that did a good job until some of, actually all your cephalosporins now and your amoxicillins and all the others. And then rifampin came along for people who had exposures to H-flu. It was a great thing to see the antibiotics change, although you still come down to a majority, to the penicillin and penicillin derivatives, and then some of the second and third year generation, I say, cephalosporins, which you use. But you had only a few drugs to use, and you used them very sparingly. And we tried not to use them all the time because we knew resistance was going to develop, so we tried to be a little bit easy on the use of medications. As far as things that developed technology, we've gone from, I can't, some of the things I don't even understand. Now it looks like Cape Canaveral in the intensive care unit. And I wouldn't dare go in. I was going to have Frank Bednarik let me take a couple of weeks up on the intensive care unit. And I said, no, I'm afraid I'll electrocute myself because I wasn't a very good technician. But those are the things that come into play. Those things now are just unbelievable. Unfortunately, I think they go overboard in saving some of these infants that just probably should not be saved. And you end up with severely retarded kids with cerebral palsy and all sorts of other problems. But they're improving them all the time, and hopefully the perinatologist will find some way to prevent the problems that develop. Immunizations are a big part of pediatric practice. I can remember when we had only the measles vaccine, and that was given with gamma globulin because it wasn't refined enough at that time. So you had to give a large dose of gamma globulin with the vaccine, and then anyway, you did get a reaction. But when you got the reaction, you knew that the kids were at least building up antibodies. Then came the rubella vaccine, then came the mumps vaccine, then they combined them to the MMR, as you know. And then came all the other vaccines that, the Hib and everything else that's around, the hepatitis vaccines, all these are all wonderful because diminish the numbers of cases that we used to have to take care of. I can remember losing a patient with measles. And it wasn't only measles, but we had measles encephalitis, and the mother was taking care of the baby, and she was giving huge doses of aspirin to get the temperature down, and the kid died from a combination of salicylate poisoning and the encephalitis. So all these things begin to be recognized, and very rarely now do you see a case of measles. I think in the last 15, 20 years, I haven't seen any measles. I did see a couple cases of German measles, probably because the vaccine didn't take on those kids. And then the public health department wouldn't believe me, because when they said I made the diagnosis, that's one thing you should be careful of when making the diagnosis of German measles. Everybody goes into a panic. And it's not that the seriousness of the disease, but the problems that can develop with pregnant people and what have you. So it ended up that I had them do pre and, antibody titers. And it showed up, it definitely was. It was rubella, rubella. And so that they apologized to me for, because I'd seen so much earlier that the new group had never seen it. They didn't know what it was like. Yeah. And so when you see a case like that, you remember what it is. And we made the diagnosis, they wouldn't believe it. But I think all those vaccines have done a tremendous, unbelievable job in preventing diseases. Grand. And I hope there'll be more, you know, because I saw the beginning. I never had a case of smallpox because we did have the vaccine, but then I can remember saying, thank God, that was the last case of smallpox, I think was someplace in Afghanistan. And there was a big write-up in the Time magazine about the last case of smallpox. And the only one, I guess, since that time was a case that was caused by a fellow who was working in a laboratory with a vaccine, and he got smallpox. So that was a tremendous boon to see that disappear, because, oh, some of the kids, when we used to do these smallpox vaccinations, they'd get violently ill with it, and their whole arm would blow up like a, you know, a balloon. It was very, very troublesome. So I was very happy when they didn't have to do any more smallpox vaccinations.
Yeah. So it seems like infectious disease as a whole must have dropped off?
Oh, dropped off, yes. And now you have an occasional case of meningitis. You have, I don't think I've seen a pneumococcal pneumonia, lobar pneumonia, for years. Now it's more viral type of pneumonias. And some of the rarities that you see once in a while. But we used to have quite a few cases of viral myocarditis in the old days. And of course we had, I think I had the last case of polio that I took care of I was a house officer at the time. I was the chief resident of St. Vincent's, and we had the old drinker, the old iron lung. And this child was in the iron lung. We had to do a tracheostomy on her while she was in the iron lung. And it was one night in September, and I think we had a hurricane around the time, and the electricity went off in the hospital. The backup generators failed. So this old iron lung you could hand pump. And myself and one of my residents did this for about 18 hours, hand pumped and foot pumped this machine so it would keep going. And I was telling somebody at the meeting we had not too long ago that we all looked like Arnold Schwarzenegger after the fact, because we were all, you know, muscles were blown up, we were pumping iron all night long. Yeah. And that was a good time. But since that time, I haven't seen a case of polio. No.
How'd she do afterwards? Did she make it, or?
She was in that respirator for about a couple of years, and then later on they developed a new type of, but she never could, never lived without some type of assistance. She had bulbospinal polio, and boy, she was a sick little girl. Her mother had refused to give her the polio vaccine. And that's what all of us use that particular case as, hey, this is what happens when you don't, you know, use the vaccine. So that was an aid in pushing that vaccine. It really was. And all the others. We still have, even up until 5 or 6 years ago, there's some still people who refuse. And even now they're doing it, as you probably know. They just don't want the vaccines. But stop the vaccines and you're going to end up with the disease. It's out there. And we had, I've never seen a case of diphtheria. My wife did when she was at Haynes, training in Haynes in Boston. She had taken care of kids with diphtheria and taken care of cases of tetanus. But myself, I'd never seen a case. So I used to ask her all the questions. And I never, she had more experience in a nursery too than I did. So one of my favorite little patients, who was born at 1 pound, 12 ounces, and was relatively strong little preemie, I said, what are we going to do? To my wife, what are we going to do to feed this child? You didn't want to put an indwelling tube in at the time because the tissues were so fragile and friable that you'd end up with all sorts of scarring and problems. So we fed this baby with formula with an eyedropper with added brandy. And I used to brag that I had the youngest alcoholic in the city of Worcester. But put a few drops of brandy, stimulate the respiratory system and the circulation, and that kid ended up being 6'2", and the last time I heard of him, he was in the Navy, as a lifer in the Navy.
So the care of premiums must have changed an awful lot.
Oh, the care of preemies has changed tremendously. Oh, it was,
You're right, too.
yeah. We had some of the crudest ways of taking care of babies. We had an old intermittent positive pressure apparatus that we used to use for kids who had respiratory distress in the newborn period. And as a matter of fact, the fellow who used to sell those machines actually became the president of FIBA, which has its headquarters on Route 9 in Westboro. And Frank is retired now, and he's a multimillionaire because he became the president of that company, which provided oxygen for all the hospitals in the area and compressed gas for all the Disney World, gas machines that they have, everything else. So he was, and even overseas, so he became a big man. He used to sell these little machines that we had. Yeah. Frank Finn, that was his name. So we've seen all these new apparatus, come out that, as I said, I'd be afraid to use today. I wouldn't even know how to use them. I could plug them in, but I wouldn't know what to do from there.
Yeah. Do you have any favorite memories that you look back on?
I think that the favorite one was some of the things that we did in saving kids' lives. It wasn't me that saved them, but we were instrumental in helping them get better. I think there was several of them. I think one of the things that impressed, that I can remember most, was a diagnosis that I made on a house call, and the chief resident at St. Vincent's wouldn't believe it. But I remember going to see this child, this kid, 10, 11-year-old boy, over at Great Brook Valley. You know what Great Brook Valley is? And there's all sorts of symptoms, complaining. I looked at him and I said, there's something strange about this young fella. He was asthenic. He had pigmentation around his cuts and bruises, and all sorts of abdominal complaints. And he looked really sick when I saw him, and I was wondering whether he might have had an appendicitis or ruptured appendicitis. I looked at him more and more, took his blood pressure. Blood pressure was 90/0, and he had the pigmentation. I tried to listen to his heart, and I couldn't hear his heart sounds. Distant heart sounds. And something made me think, one of my pathology professors said, remember, if you've got pigmentation, a wide pulse pressure, distant heart sounds, and an asthenic build with a lot of complaints, think of Addison's disease. And this is exactly what he had. I admitted him to the hospital that night. His serum sodium was 112. His potassium, I think, was 7 or 8, something like that. And the endocrinologist who was at St. Vincent Hospital at the time got out of bed to come in because he wouldn't believe it either. And he was thrilled. Oh, we'll be able to write this case up and present it. He said, 11 or 12-year-old boy with Addison's disease? He never heard of it. And at least not, and there was no, it was idiopathic Addison's disease. And it turned out to be one of the better cases, and a thrill for me to have, thought about it. But we've had some very serious cases too. I think the one I went home and cried about one night was a little girl that came into my office, Carolyn Reedy, her name was. And she was a little giddy. She was complaining about a headache, an upset stomach, and inappropriate responses. And I said, oh, good Lord, what have we got here? I think she's got some sort of encephalitis or some strange picture. So we admitted her to the hospital, and it was an ice storm. She went in the hospital about 12 noon. And the chief resident called me, said, I think we've got a real problem. She was good when she came in, but now she's getting worse. I said, what's the matter? She says, she's really starting to go into a coma. And I said, well, I said, I'll be up as soon as I can. I finished the office. So I had a friend of mine, I had him, he had been in practice for a year or two. I said, we need some consultants here in this case. She turned out to be probably the first case of Reye's syndrome we had here in Worcester. And we called Cleveland, we called Cincinnati, we called every place that was, as a matter of fact, I think the week before, an article had come out in the Green Journal of Pediatrics about this new syndrome. Reye's syndrome, they call it, Reye's, R-E-Y, R-E-Y-E-S. It's a hepatoencephalopathic type of illness. And at the time, there was no treatment for it. So that what we did at that time, we called up and they said, the only thing you can do, he says, there's a toxin that's circulating that's giving this child a problem. You will probably have to do a total exchange transfusion. By the time we got enough blood typed and crossed for that girl, she had died. And the father and I sat outside and we cried. I went home. I went home about 5 o'clock the next morning. I sat down, and she was the age of one of my own children, one of my own girls. And I think I sat down, I cried for about 2 or 3 hours because we just couldn't do a thing. And nowadays you don't hear too much about it because they felt that there was an association between aspirin and some of the flu, like symptoms plus chickenpox, that allowed this encephalopathy to develop. So that's the reason why you use Tylenol and not aspirin with flu. So that, but we studied that and studied and studied it, and we had a few other minor cases, but never went to the point where we lost one. But there were still more cases around. Haven't seen that for ages. So that some of the cases we had were very good, some were very bad. I did have one that I was thrilled about. An 8-month-old baby who came in for a routine visit, and I examined the little scrotum and I found a little hard lump on one of the testicles. I said, oh, I don't like this at all. This is a hard mass, separate, attached to the testicle. So I called up the urologist, the chief of urology here was Dr. Diamond at the time. He's gone, he's in Boston now. And they came right over here, did a biopsy on the child, and it turned out it was a malignant, the name is about this long, but there are only 6 other cases in the world of this particular type of tumor, and none of them were children. They were all adult males. So that it was a thrill. And then since that time, I've heard, she moved to Australia. She sends me a little note every once in a while telling me how he's doing and everything is fine, and there's been no recurrence of the disease, which is great. So those are the rewarding aspects of pediatrics, really. Very, very rewarding.
What sort of advice would you have for a young physician or medical student just entering into the field?
I think one of the most important things that I've done when I've made rounds with interns and residents over the years is listen to your mothers and fathers. Take time to really listen, and you can make it come down to probably 3 diagnoses when you're seeing a child if you listen and question the mother and listen to her. They have a certain instinct and intuitive knowledge about their own children, and they can tell you things that you probably wouldn't think of asking. But if you listen to them, you can come up with the answers very well. I had an internal medicine professor at Boston City Hospital when I was in 3rd and 4th year clerkships and clinics, that he used to make us, just from the history, come down to 3 diagnoses. Then he would say, okay, now you can go out and examine the patient. And then you have to come down to 2 diagnoses. And then and only then will I let you order any laboratory tests. And then you have to know the price of every lab test that you order. So he made us very conscious of the economics of medicine, as well as how to, diagnose. His diagnostic ability were fabulous. And this is what I used to love. I'd spend a lot of time with my parents and my patients, even asking the kids who are old enough to, find out. And they helped you tremendously if you just give them the time to talk about their illness. But to pass it off very carelessly and say, oh, well, this is just going to be headaches particularly, because many times we came across some headaches that turned out to be brain tumors or some severe problems and kidney diseases and things of that sort. So you really have to be, listen to the history, do an excellent physical exam, and then and only then do you start thinking about the esoteric. It's going to be the most common thing that you'll probably find frequently, but if you can't find a common thing, then start looking for the esoteric ones. But you really have to be a listener, a real good listener. And then you have to know, and then as time goes on, then you can cut the number of questions that you have to ask down to a minimum, and you can get right to the heart of the matter. And then those are the things that I'd like to tell. And not to worry about your financial status is in medicine. At the beginning, I can remember my first 6 months in pediatrics. I think what I made in the first 6 months in the year I went in practice, $10,000, I think this was, And you're not going to be rich doing pediatrics. You're not going to be rich doing any medical profession really right now, because if you want to make money, go into business, into computers and things of this sort. But you've got to love people. You've got to love to take care of them. And if you're that interested and sincere and honest, honesty is an important part. If you don't know the answer, tell them you don't know, but you need help. Oh, we're going to do this, do that, the other thing. But you've really got to say, gee, I'm sorry, I'm having trouble deciding what this particular disease is. Let's give it a little time, let's do a few tests, and then if we can't, then we'll get somebody to help us out. But I knew a couple of doctors, and unfortunately, who felt that they could not tell people that they didn't know what was going on. And I think that sets up a barrier between you and the parents or your patient. Honesty is a great thing, and it's a virtue that a lot of us sometimes forget that's important. Humility, too. You can't be a kingpin and think you know it all, because you just can't do it.
You brought up the relationship between doctor and patient. I was wondering how that changed over the years of practicing.
Well, I think in my own personal life, I tried not to make a change. I tried to be as honest and part of the family. But I think what has happened with the influence of the HMOs, the different insurance companies, and the rush to see as many patients as you possibly can, you cut the relationship down, because people are being ushered out, rushed out all the time. And you don't get a chance to know them as well as you like to. And that's what I always wanted to know my parents and know the kids. And even to this day, I'll have a bearded guy come up to me and he say, "Hey, Dr. Donovan, don't you remember me?" I said, "How can I remember you with the beard?" And you have to tell me his name. Then I can go back and say, "Oh, yes, I can remember." But I have a lot of, that happens quite a bit. But there's too much formality, I think, nowadays, and too much of, what do I want to say? I'm not sure about the word, but we should still be, have a fatherly attitude or parental attitude towards our patients and be interested in them wholeheartedly. Put your whole heart and soul into taking care of them, and not giving up. I think that's an important part of young fellows. And you won't have to worry about success in your practice if you're sincerely interested in your patients, and don't cast them aside. Oh, you got an ache here. Oh, it's just this, just that. That happens too frequently now. It really does.
You brought up managed care coming in, changing things around a little bit.
I think so. Again, I think that becomes too impersonal. The managed care has really restricted and put a lot of restraints and constraints on what a doctor can do. And you see that in the paper practically every day about so-and-so is suing this one, he's suing that one because he wasn't allowed to have this done, he wasn't allowed to have this surgery. And that's a shame. There's got to be some way to get around this, because doctors now are being, well, criticized a tremendous amount. Years ago, you never heard of anybody suing a doctor because you were part of the family. And you were honest with people, and you weren't concerned about that almighty buck, and trying to make as much as you possibly can. And I would say that my generation of docs have never been like that. And we hate to see this invade, the younger people, because it's, you just want to see them love your patient, take care of him as best you can, and everything will work out for you. You'll be a success. I can remember Dr. Robert Johnson, who was a neurosurgeon at St. Vincent Hospital and throughout the city years ago. He's retired. But his first lecture to the interns at St. Vincent's was, what do you call it, the 3 A's. Availability, affability, and ability, in that order. He says you'll become a good doctor. Availability, affability, and ability. And he said, if you practice those 3 virtues, he said, you'll do well. And he said, just be around for your patients. And then if you can't be around, then make sure that there's somebody adequately, covering you. That's the important part as well. You just can't go off and leave them in the lurch. If you do now, you get sued.
Did Mass Health change around how you could treat patients? Or a patient's ability to care?
Well, I think that improved it. It gave people who are really indigent a chance to, utilize the system to get the help. Unfortunately, there were some hang-ups with the welfare, Medicaid and Medicare. When the state was running it years ago, I can remember a situation that developed with me that the public health department in the state of Massachusetts was starting to owe me more and more and more. They weren't paying. And so they were up to something like $30,000 or $40,000 that they owed me, and at that time, that was a lot of money. And one day, I got a letter saying, I'm sorry, the Public Health Department of the state of Massachusetts has no more funds for this particular period. We owed you so much, but now we owe you nothing. Now, if you did that with your income tax, your state income tax, what would happen? You'd end up in jail if you didn't pay your bills or pay your taxes. That hit me once. And then same thing happened early in the Medicaid. They built up huge amounts that they owed a lot of us, and then they just signed it off. Now it's become a little bit better. Granted, they've reduced the amount that they're giving hospitals and giving this place and that place. They really don't pay some of the physicians what they're worth, but it is better than not getting paid at all. But there was a lot more charitable work done in those years. We used to have lines of people who, they'd come in with a cake to pay you for the office visit. And I even had people come in with their bags of tomatoes that they had in their garden in the summertime to pay me what they owed me, or else you'd have them pay 50 cents a week for, 20 years, something like that. And you didn't mind because the intention was good. They wanted to give you something. They didn't want to be so-called welfare patients, but they wanted to pay their way. It has changed for the better, but I don't know whether total socialized medicine or national health insurances, they can't find the answer yet, and I don't know whether they ever will. It's got to be some help, though, because the price of medicine, as you know, has gone so sky high that the care has been diminished a little bit, I think, too, because of the price of the care. And there are guys who, I'm quite sure Lenny Moss got into talking this with you. Did he, Dr. Moss?
A little bit.
A little bit? Because he was instrumental in a lot of social welfare changes throughout the state. He was a fabulous guy. Lenny and I used to have coffee quite frequently in the morning at St. Vincent Hospital and talk about cases that we had. His in the adult field, mine in the pediatric field, and I used to use him as a consultant too, as infectious diseases. But he was a good man.
I'm not sure how much time we have left.
Have we got much time?
Is there anything you'd like to talk about in the remaining couple minutes?
Not really. I hope I gave you sufficient amount of insight or what have you, or something that you can hang on to. Yeah. Now, what happens with this whole thing now?
I go and I sell it on the streets of Woodstock.